Today we've got Dr. Colleen Sicard, one of our newly minted staff physicians, board certified, and she's going to be talking about preventative care in pediatrics, the guidelines, especially the Bright Futures guidelines. I mean, this is something that all of us do to some degree, and especially for residents and attendings in the pediatric clinic. So we're looking forward to hearing what Colleen has to say.
Thank you. Did y'all get our humongous handout? They printed it on really huge paper, but I guess it'll be good for when you're in clinic. I don't know if y'all want to, do y'all want me to pass some back to the back? Do y'all want some? There's a good amount up here. So, because I'll be following this throughout the whole presentation. Yeah, so it is kind of good to have. This is the up-to-date 2014 Bright Futures guidelines, okay? So this is the newest Bright Futures periodicity schedule that we have, and so that's what I'm going to be going over today. When I was studying for my boards, one of the lecturers on our med study DVDs said to memorize this, and so I started memorizing it. Most of it we already do. There's a few things that I didn't really know at the time as I was studying for my boards, and so I thought that this would be a great overview for our grand rounds. But really, each one of these subjects that I'm going to go over could actually have its very own grand round. So I'm going to kind of skim over and go as fast as possible because I don't want it to linger too long. So our objectives today are to define the AAP and Bright Futures guidelines for preventive care visits. I'm going to illustrate the importance of comprehensive continuity of care without fragmentation, and then I'm going to explain how to implement these guidelines into our everyday practice. I don't have any disclosures to make. So this is the periodicity schedule. Before today, how many of y'all have actually ever laid eyes on this? Good amount. So there's a key at the bottom. If you look at the bottom right-hand side of this schedule, you'll see that the circles on here is what needs to be performed at each visit. So across the top is ages, and down this axis is showing different things that need to be performed at different visits. The star is if you find a risk, then you need to delve further into that risk. So we'll kind of go through those. So the first visit, I'm going to go in the vertical axis first, and then we'll go horizontal. But the first visit is the prenatal visit, okay? And so the only thing recommended at this visit is history. You see this a lot more in the private practice world, where parents come in and they're looking for a pediatrician that kind of has the same ideas as them on how to care for their child. And so it's recommended for all high-risk parents, for first-time parents, and for anyone who requests a visit. So they can be a G6 or whatever and still want to come visit with you. And so the big thing that they want us to do here is discuss the benefits of breastfeeding. And so that's the biggest part of our prenatal visit, and this is where we get a history from mom, and that'll be good for going into the future. You won't have to ask as many questions in the newborn period and then in your 3 to 5 day exam. So next is our newborn exam. And so every single infant should have a newborn exam prior to discharge, okay? And we'll go into what that exam entails later on. But for right now, breastfeeding is the biggest thing that we need to encourage during this exam. And so if you look at the policy statement from the 2012 AAP, breastfeeding and the use of human milk, one of the first sentences in there says, given the documented short and long-term medical and neurodevelopmental advantages of breastfeeding, infant nutrition should be a health issue, not only a lifestyle choice, okay? So it's a public health issue, not just lifestyle choice. So then this is a 3 to 5 day old exam. I feel like we're really good at doing this for our breastfeeding mommies and maybe not so great for our just run-of-the-mill formula-fed moms. So the AAP recommends that every infant from the ages of 3 to 5 days old should have a visit or if they're in the NICU or something, or they're in the hospital for a prolonged course, they should be seen within 48 to 72 hours of discharge, which we do that pretty well also. And at this time, we're again going to encourage breastfeeding, and that's from that 2012 policy statement that I talked about. And then the 2010 AAP policy statement, this is when they recommend the 3 to 5 day old visit, okay? And this is where you look for feeding issues, jaundice, those type of things. So,
mommy issues too.
And oh yes, definitely mommy issues. Y'all know I'm a big proponent of peripartum depression, and so that is a huge thing to start looking for at those visits also. You can actually do that in the prenatal visit and from then on. So depression is huge. So now we're going to go across the horizontal axis and we're going to talk about history. So these are all of the different times we should have visits with our patients, okay? And so I think that these are huge. So prenatal, some we may or may not get those, but the newborn, the 3 to 5 day visit, and then by 1 month. You need to have 3 visits within that short span of time, okay? So this is going to be covered here by our nursery doctors. But then we still need to see them twice before their 2-month visit, okay? And so I think that's really important, something that we need to probably start implementing a little better maybe. We always do all the rest of these really well, I think. 2 month, 4 month, 6 month, 9 month, 12 month, 18 month, 24 month, and then 30 month. And then once per year, and the AAP Pediatrics is until they're 21 years old, okay? In our clinic, we only see to 18, but AAP recommends to 21. So in the private world, you'll probably definitely be seeing some 21-year-olds in your clinic, maybe even a little further. They kind of hang on for a while. So, and then those are once per year. So once you hit 3 years old, once a year. And so I know this is kind of big and obnoxious, but so you don't get lost in all the numbers that I'm putting on there, I'm going to put this big picture slide every time. So history should be done with every well child visit, and of course if they're well child or not, should be getting a history. So next on, if you're moving on down the vertical axis, is the measurements. So at every visit that we just went through, you should be getting either a length or height and a weight at that visit. This is, sometimes you don't see this in every private practice in the world. So something that you should definitely implement. We do this every visit that we have here. So every well child visit and not well child, we still do it here. So head circumference, you should do it every visit until they're 24 months old, okay? So every time you see the kid until they're 24 months old, measure their head, okay? Sometimes people forget to do that. That's very important. Length for weight. We're going to do that until 18 months of age. So you're not using BMI yet, okay? So it's just length for weight. Once they turn 2, you're going to start using your BMI, okay? And that's yearly. And that was recommended in a 2007 AAP policy statement, okay, and on obesity. And so as y'all know, the BMI chart that we use in clinic, this is for boys age 2 to 20. And so of course you want them to be in the green range from the 5th to the 85th percentile. So starting at 24 months old, every kid should get a BMI done. Blood pressure, this is big. Starting at age 3 and every year after that, you should start having blood pressures. Now if there's some type of red flag, again, that's where the star comes in, then you need to start doing it prior to age 3. But starting at age 3, every child should have a blood pressure done. Okay. So now we're going to go to the next step is sensory screening. So vision screening is starting at 3 and then it's kind of random years throughout until 18. And then if you have any concerns prior to age 3 or in between periods, then of course screen them, okay? So this is the Snellen charts that we use. This is for younger children, and then older kids can start doing the letters and then colors too. So starting at 3, vision screening. Hearing screening. We do this, as we all know, at the newborn period and then again at 4 years old. Usually in between there, they're not really going to cooperate very well with a hearing screen, but if you have any concerns at all, again, screen them in between these times. And so that is a huge thing too, is used to the AAP didn't recommend on every single newborn having a hearing screen. Now every single newborn prior to discharge needs to have a hearing screen. Next is our developmental and behavioral assessment. So developmental screening versus surveillance. Do y'all know the difference? Anybody? I know y'all know. So screening, how many times would y'all say we should be doing developmental screening until they're 21 years old? Just throw out numbers, it's fine. Like with an actual tool, okay? So surveillance is what we do at every visit, okay? We're looking at what their milestones are at every visit, but we're not using an actual tool at every single visit, okay? So when you use a screening tool, and it doesn't matter what y'all use, here we use the Denver. There's several different ones on the market, the ASK, several different ones. So here is the Denver. The first time we should do it is at 9 months, second time 18 months, third time 30 months, and that's it. That's only 3 times we should be using an actual tool to do screening, okay? Which is different, like I said, from surveillance. So the surveillance should be done at every single well child other than those 3 that I just mentioned, okay? So that's just asking mom, what are they doing? You know, you go off of the milestones that you just feel comfortable and get in that routine of asking. But the screening is at those three different areas. So again, and it should be done every time. Autism screening. How many times do we do autism screening? Do y'all know? Twice. 18 months and 24 months. It used to be either or. Now they recommend doing it at both visits, okay? And so we do that now with the MCHAT-R, okay? Make sure it has the R for revised. We have these all over the clinic, continuity everywhere, and I've made answer keys for all of them, okay? If there are any red flags for any of them, then you go to the MCHAT-RF. I didn't print that out because it's like a 50-page document. And so then you just Google MCHAT-RF and go for your specific number that you need to ask, and do that in the room with mom on the computer in the room, okay? But that is one thing that I was missing. I was either doing it at the 24 or 18-month visit. I wasn't doing it at both. And so that's something that the AAP now recommends in the 2014 guidelines, okay? So do it at both visits. So psychosocial behavioral assessment at every single visit, okay? That whenever you see them, check psychosocial and behavioral. This is new for the 2014 guidelines, alcohol and drug use assessment. So we do it on adolescents with risk. So that's what the STAR is for, okay? So, but at every well child from 11 to 21 years old, you do a risk assessment, and then you go further with the craft questions. So what they recommend doing is you ask these first 3 questions. If there's no concerns, then you can just do the first 3 of the craft. Are y'all familiar with the craft questions? So C is for car, R is relax, A is alone, F forget, the next F is for family or friends, and then the T is for trouble, okay? And so what you do is you ask the top 3 questions, and then if there's any yeses, then you go through all of the craft questions. If it's all no's, then you just ask the first 3 of the craft questions, which is CAR, C-R-A, or whatever. So that should be asked to every single adolescent that comes into clinic. And so also, this is new for the 2014 guidelines, depression screening. This is not risk. This is for every single adolescent that we see should be screened for depression. And it's just a 2-question screening. So the PHQ-2, I thought it was very interesting because it's only 2 questions, and a score of 3 or above shows 90% specificity for major depressive disorder. So this is it right here, okay? And that's all you have to do is ask these 2 questions, and then move along, okay? But this is supposed to be done for every single adolescent that we see. So the first question I see people kind of straining, little interest and pleasure are doing things, and so you rank it not at all to nearly every day, not at all 0, nearly every day is a 3. Feeling down, depressed, or hopeless is the next question, and then you rate those, okay? But a 3 or above, 90% specific for major depressive disorder. But we have to do this on every single adolescent that we see, okay? Physical examination, all across the board. So we're going to do that for every single well child exam, okay? So we're building up different things for every well child exam. There's certain things we should be doing for every single one, okay? So now we're in the procedure section. The first one is the newborn blood screening. They've renamed it. It's not the metabolic screen anymore. It's blood screening is what they're calling it now. And so sometimes you'll get patients born at home or from a different area, and maybe they don't do the newborn screening before they're discharged from the hospital. And so you have a window when it's okay to do it. So when from newborn period to 2 months old is an okay frame of time to be doing the newborn screening. And then of course it's on you as the pediatrician to follow up the results of that, okay? We also have kids in the NICU that were on TPN or whatever. They got blood transfusions, different things like that, to where you have to repeat the newborn screen. This is just for, the whole periodicity schedule is for well child, full-term type babies, okay? So that's what this is talking about. So we do it on every single baby. This is something new for the 2014 periodicity schedule. So there's a 2011 AAP policy statement saying that we should screen every single baby for critical congenital heart defect, okay? And so we're gonna do a pulse ox after the age of 24 hours, but before they're discharged from the hospital. So you do a pre and a post-ductal pulse ox. And so this is from that paper, what they did. Where's my mouse? Here it is. They screened 13,000 kids, 13,714. They did pre and post ductal. If the SAT is greater than 95% and the difference between the pre and post is less than 3, then you're fine, okay? If the difference between the pre and post is greater than 3%, then they repeated it, and of that 37 passed, 1 failed. And so you just keep moving down this algorithm, okay? And they recommend, of course, pre is going to be right hand, and then they just say right foot, just for, it's easier to remember, just do them both on the same side for the nurses. So right hand and foot is your pre and post, okay? But from this screening, as you can see, only 8 kids of this 13,000 had echoes, and only 2 of those had critical congenital heart disease, okay? But it's a great screening, and now it's recommended on every single infant that's born in the newborn nursery, okay? Immunizations, of course, do this at every single well child visit, and AAP, just like on your boards, every time you see a kid, I don't care if it's in the ER, I don't care where you are, look at their immunizations and get them up to date. Your boards will definitely have a question on that, okay? And so every visit you see them, just check their links and make sure they're up to date, okay? Hematocrit or hemoglobin. So you don't have to do both. We usually do both. And they recommend, the AAP recommends at 12 months. We usually do 12 and 24 months just because of, mostly because of our patient population that we're seeing. We do see a lot of kids with anemia for various reasons. AAP recommends only doing it here, but also doing your risk assessment. So this 4-month-old risk assessment, that's a preemie baby. Most preemies should probably have a hemoglobin or hematocrit at 4 months of age, because if they didn't go through the 3rd trimester, they didn't build up those iron stores like the rest of our term babies do. So just do your risk assessment, and at these different ages, you can get a hemoglobin or hematocrit. Okay, and it doesn't say a CBC with differential, so it's just real quick type screening. So lead screening. This, again, we do this very well. 12 months, 24 months, okay? You can do the risk assessment at these various ages. We see lots of elevated lead levels. They are supposed to be reported. Do y'all know when are you supposed to report? With the new recommendations the CDC just came out with in 2012, what level are we supposed to be reporting? Anybody know? 5, okay? So anything greater than or equal to 5 needs to be reported, okay? It used to be much higher than that. So now 5 needs to be reported. And so there's a huge policy statement from the CDC going into all the different reasons why. And so it's actually very interesting, and maybe I'll do a grand rounds on that next. I don't know. I think it's very interesting, and it's something that probably needs to be followed a little closer in some areas. I think we're actually very good at it here. But yesterday I had two siblings been living in the same area, numerous calls, numerous canceled visits, no-showed visits. The little boy's lead was 14 and the little girl's lead was 12. So anyway, they've already had a screening at their house. Somebody's been out to visit their home, but they got lost to follow-up just because of the family situation. So it's something that needs to be followed closely so that we can prevent ADHD and different things like that, developmental delays. So, okay. Tuberculosis testing, this is new for the 2012 guidelines, okay? It's not something that's recommended at any age that everybody has to get across the board, but you do need to be doing a risk assessment, okay? And so every kid by the time they're 1 month old should have a risk assessment done. And then at 6 months, 12 months, 24, and then every year from 3 and above. And then you go and do the testing from there, okay? So what's the best way to test for TB in a kid that's not coughing up sputum? What do we usually do? Well, I guess testing is one, how do we diagnose it? What's the best way? The early morning gastric aspirates, okay? So that's an intense type thing. If you really think they have TB and they're a young kid, you're probably gonna have to admit them so that we can get those early morning gastric aspirates, because I don't see that really happening very well on an outpatient type basis, okay? The TB test, most immune competent kids, you can do, you know, the Manitow test and put it on their arm and test it, but 10 to 40% of immune competent kids are gonna have that as negative. So the quantiferon gold, which is what we have here, is the blood test. It tests the T-cell reactivity. That is gonna be probably a little bit better, actually, at testing than the skin test. So, but that's in kids 4 years and older, okay? So anyway, this is risk assessment, which we didn't have before, but all this is per the Red Book. So you can look up all that information in the Red Book. So, yes, sir.
Solidify that, you know, years ago we used to do mass screening of everybody on a routine basis. That's long gone, and it's all going to be based on risk. The PPD is still the recommended. Okay. Well, either test is okay to use, okay, but neither one is particularly good under age 4.
Right.
So we know it's an imperfect diagnostic scheme, and the risk factors are as important as anybody, okay, as anything in the process.
Great. Thank you. Okay, dyslipidemia screening, this is huge, okay, because this is a newer recommendation from the 2011 guidelines, okay? So we do it twice, and we should do it between the age of 9 and 11, and then again from 18 to 21. So a lot of the 18 to 21-year-olds in our clinic, we don't see 18 really or above, but that 9 to 11-year window, and they recommend a fasting lipid panel, okay? But I think also what's huge is you start looking for risk factors at 24 months. If you have a kid and that's the first time you're doing their BMI, okay? If their BMI is elevated, then you probably should think about doing a screen right there, okay? Especially if there's family history of anything, obesity, anything like that. And so I think this is one thing that's newer, and we maybe aren't doing it as much as we probably should be. Okay. Questions about that?
So it's the pre-adolescent visit, 9 to 11, when you're talking about HPV, think about difference.
Right. Go ahead and do it there, and then again at the 18, anywhere between 18 and 21. So those aren't risk assessment. Those should be done. Okay. The STD and HIV screening. So I thought this was very interesting that this is not a risk assessment. This should be done between 16 and 18 years old, okay? And this is no matter what they say their sexual history is. You can't test someone from 16 to 18 years old without telling them you're doing it. So, of course, you just tell them, we usually do this at this age. They can opt out of it if they do not want it, and that's fine. You know, I swear I haven't, no. But some kids may not obviously be truthful with you. So just say, we do this at this age. You can opt out of it if you don't want it, but we would recommend it. And then risk assessment should be started from age 11 up. So, as y'all know, we do this all day, every day, but there's some kids that are going to come in for just a routine well child, and you know, that's when you just get mom to step out of the room when you're talking about all the other questions that you're going to be going through, especially their depression screening. At the same time, you just talk about this while mom's out of the room, okay? And some of them will then come out and say, yeah, maybe I should be tested, but you should give them the option, okay? So cervical dysplasia screening, I had a question on my boards about this. Your first pap smear should be at 21 unless they're immune suppressed or they have HIV, okay? And so it should be with the onset of sexual activity. So that's something that we don't really think about that much anymore because we don't do pap smears really, but if they're immune suppressed, so we have tons of patients on chemo, they're on several different things for rheumatologic disorders, whatever. These are immune suppressed kids. If they come in, they're sexually active. These are things we probably should be catching on the floor. They come in for Remicade, stuff like that. They need a cervical dysplasia screening and they need it yearly, okay? Oral health. This is big, and actually they're the new guidelines, so they don't come out with this every year, but they are actually going to come out with this again in 2015. It's not something that comes out every January or something like that. The one before this was 2009, okay? This year, the oral health guidelines are going to change a little bit, so this spring, this section is going to change just slightly. Oral health exams should be started no matter what by 12 months old, okay? And then again at 3 and 6 years, they definitely should have a dental visit. And of course, we recommend every 6 months. But the risk assessment actually should start around 6 months. So the time you see their first tooth, you should start recommending that they brush their teeth. And there's new guidelines that just came out last year about using toothpaste. Y'all know what they are. When do you start using toothpaste? Anybody know? A smear or a grain of rice size on every tooth that erupts, okay? So you don't wait any longer. It used to be that we waited no fluoride in the toothpaste until that they were 3 years old. Now it's on every tooth, so immediately once they have teeth, you can start using toothpaste, okay? But it just use a smear or a grain of rice size on the toothbrush. And so the oral health exams need to start by 12 months. I think probably what they're going to incorporate there is the use of fluoride, okay? I'm not really sure exactly. They didn't go into it. I talked to Jessica helped me talk to the lady with Bright Futures. And then, of course, anticipatory guidance at every visit that we see them. Okay, well child or not, they need to have anticipatory guidance. So now we have kind of a list at every time we see them what should be done. So always a history, a physical exam, the anticipatory guidance, okay? And then developmental surveillance or screening, depending on where we see them, Okay, those are the 4 big things that every time you see them you need to do, and then everything else in between there that we talked about, okay? Here's my references. Questions. I kind of flew through that. I thought I would go a lot longer, so I don't know. I was just rolling. I wanted it to be an interactive thing. This was a little bit sooner than I thought I was going to be presenting this, so I'm sorry if it was really boring. I usually like a little more interaction. Questions about anything? Did y'all learn anything? Yay!
Somebody who doesn't do this.
Yes, sir.
Since you have to go through 40 patients a day to make a living in pediatrics, how much of this can be done by the nurse or law staff?
I would say that most of it, except for, of course, the physical exam part, most of it can be done by ancillary staff, okay? So med techs or whatever, you can have them doing, you know, all the questionnaires and different things like that. They can get the history for you. They can hand them the developmental screening tools. And so Miss Tracy is awesome with all of that. In our kid med, we have in our continuity clinic, Miss Tracy's our nurse, and she already has almost all of that done. She will do, that is one thing I told her about a few months ago, is the MChat needs to be done twice, because we were only doing it at either the 18-month or 24 visit. So, and another thing, Dr. Vancheri is on the committee, that the state committee. So what the state committee has recently done, and will actually be updating soon, is that they have implemented this for all 5 of the Medicaid plans, okay, which is awesome. In the spring, they're going to update it to the 2014 periodicity schedule. Right now, it's the 2009, and that's why we're still doing UAs on some of our kids. As y'all notice, that's not on here. I didn't talk about that at all. So on your boards, there is no recommended screening with a UA any longer. That's a question they'll try to ask you about. We no longer recommend that, okay? There were too many false positives, too many workups for unnecessary things. Of course, if they come in with complaints and stuff like that, then do a UA, but that's not a screening tool any longer.
Patients are assigned to the residents. Continuity plan. Who does do you get help from the staff, or does the doctor have to do everything?
No, that's Miss Tracy's our nurse in our continuity clinic. And so she does the screening tools for us. She does the lead screening. She does all the different questionnaires.
That includes sick visits as well?
That's not sick visits. That is only well child visits.
Okay.
And she does, so our kid med, that's what, so kid med, are y'all familiar with what kid med is? Probably the med students aren't really, but kid med is what the state per Medicaid requires, and they just kind of go through, they have their own periodicity schedule, but like I said, they're updating it, and last year implemented the 2009 Bright Futures schedule, but they go through all of this stuff and do, yes, they do it all these different visits per Medicaid, because we get paid for it. So, and you get paid better for a kid med visit than you do for just a routine well child visit, okay, through Medicaid. So, but yes, we'd have awesome help in our clinic, and there's certain things that I think, like our kid med nurses, they have different things implemented in their clinic where the kids will just get on the computer and click through some of these questionnaires, and then the nurse checks it after. So I think we could probably utilize that a little better. I don't know if they have like the PHQ2 or anything like that on there, but they probably should. Okay. Questions? Sorry, it was so boring.